onboarding, and make sure to slide it.
Yeah. Well, thank you for coming. This is part of our mini series on universal basic income. Today we have a really cool paper from the United States. It links in all sorts of interesting health data. We've got Sarah Miller presenting, and I'm really lucky to have that because she's a very well-known health economist. She's done very important work on healthcare, health insurance, incentives, markets in health. And it's really nice to have that perspective and expertise brought to this question. So without any delay, I'll hand over to you, Sarah, and we will ask questions as we go.
Great. Sounds wonderful. Well, thank you so much for the chance to talk about this work. This is joint work with Beth Rhodes and Patrick Krauss, who are both at Open Research, the nonprofit research organization that supported this study, Alex Bartik at University of Illinois, David Brockman at Berkeley, and Eva Vivalt at Toronto. And in this study, we're looking at the effect of a large unconditional cash transfer on health using data from a randomized controlled trial. So we use a little bit of data from the US Census Bureau, so I'm required to put this disclaimer up when I present the results that these are the views of the author team and not the federal government, and that these results were reviewed to prevent any kind of inappropriate disclosure of private information. So without any further ado, I could start talking about the main motivation for this talk, which I'm sure I don't have to describe to you, but one thing that I think was really exciting us about going down this avenue of research is this very widely documented and strong correlation that we observe between income and health. I'd argue this is perhaps one of the oldest, strongest, most well-documented associations in the social sciences. We can see this relationship, this association, the fact that higher income or higher SES people tend to have better health than lower SES people. For essentially any measure of health you might want to put on the left-hand side, whether it's mental health, chronic disease burden, mortality, longevity, you name it. If you're in a higher income group, you're probably doing better. We can see this from any time periods, starting quite early when data became available and up through papers being published this year. We see this pattern within countries, all types of countries, high income countries, low inequality countries like in Northern Europe, certainly in the US. And we can also see it across countries if we do cross-country comparisons. And it emerges very early. We see infants in the United States who are born into high-income households have infant mortality rates that are about half those of infants born into low-income households. And so we see this sort of the very start of life, and then throughout old age, even if as we look as people age, those that had higher earnings during their prime earning years have better longevity and better health. And I just want to emphasize that these differences in health across the income distribution are not small. They're enormous. There's many papers showing this, but one nice paper using data from the US is by Chetty and co-authors, published in JAMA using the tax data. And they show that for a man, if you're at the top of the income distribution at age 40, you can expect to live about 15 years longer than a similar person, similar in terms of demographics, at the same age at the bottom of the income distribution. So a decade and a half of additional life at age 40, I mean, that is a really big chunk of the expected number of years that you're going to live. So that's these kind of very stark differences, I think, are very intriguing. Of course, we know that just because things are correlated doesn't mean there's some sort of causal relationship underlying the correlation. It could be that this is driven by a third factor or that there's reverse causation. But I think in the context of the US, where we're going to do this study, it's quite plausible that the relationship may be causal. We don't have a national health insurance program. We don't have any kind of national healthcare program. And so we know that lower income people in the US are less likely to have any insurance. It may be very costly for them to get medical care. They're much more likely to report skipping or delaying medical care because it's too costly. We also see on the behavioral front, they tend to have worse nutrition. They tend to be more likely to report lower quality sleep or that they're sleeping fewer than 6 hours a night. And so we might think that if we do a cash transfer, we could either make it easier for them to afford medical care, healthcare is a normal good, or it could make them easier to consume better nutrition or invest more in their health. But I think even if this transfer doesn't change this type of consumption, there could be reasons to think it may improve health through biological channels. We know that stress is linked to kind of chronic inflammation, which can in turn have all kinds of bad detrimental effects on our physical health, like increased cardiovascular disease or increase the risk of some types of cancers. And so if the stress of being poor is leading to this inflammation, then perhaps a cash transfer can decrease that stress and improve health through these biological channels. So this kind of constellation of correlations and data has, at least in the US policy space, a lot of policymakers starting to think, maybe if we want to improve health and reduce these health disparities, maybe it's better to spend our marginal dollar on addressing these material needs, addressing the economic factors that are correlated with health, rather than maybe the traditional path of increasing access to medical care. Or put differently, I suppose if we have one more marginal dollar to spend on improving health, perhaps it is more productive providing that dollar as a cash transfer or providing some other kind of material need like housing or improving neighborhood, rather than spending that on more medicine or more interventions. Of course, this sort of idea rests on the sort of assumption that these patterns do reflect a causal relationship and that there is some policy that can intervene and improve economic circumstances and then improve downstream health. So that's kind of where we're jumping into with this RCT. And we're doing this to, and I should say, if you have a question, just speak up because I might not see you raising your hand. We're looking at a randomized controlled trial that we conducted in the US called the Open Research Unconditional Income Study, or we abbreviate ORIS. We thought open research unconditional, open research guaranteed income study, but that is ORGs, so that's like a little bit of a weird abbreviation. So we're calling it ORIS. In this study, we had 3,000 participants. 1,000 of them were randomly assigned to receive $1,000 a month for 3 years, with 2,000 serving as a control group getting $50 a month over the same period. So this was a low-income sample. I'll tell you a little bit about how we recruited them. But this was a pretty large transfer relative to their baseline income. So this is about 40% of an increase relative to their household income and more of an increase relative to personal income, and for a pretty long period of time. The sample oversampled the lowest income participants in our eligibility group, and it's a sample that reported pretty high baseline health needs. We had about a quarter of the sample saying they needed some medical care that they just couldn't afford. We had about a third of the sample saying they needed some dental care that they couldn't afford. So again, in the context of the US, where not everyone has insurance, it seemed like a sample where it was plausible that this intervention could improve people's health. And then we collect a wide range of information on what, as economists might refer to as health, inputs, things that you might consume to improve your health, and then health outputs like self-reported physical health, mental health. We did blood draws to measure different underlying clinical measures of health, and we have records of mortality. So we're going to look at how this transfer affected these sets of outcomes. So what do we find? We find that the transfer did have large improvements on things like stress and some measures of mental health, but they were somewhat short-lived, which was surprising to us. We see a big improvement in the first year, but by year 2, we see that the treatment group and the control group are reporting very similar levels of stress and similar quality of mental health. So improvement in mental health, but it doesn't seem to be sustained. We do see that the group that received the larger cash transfer used more medical care, especially hospital care, emergency department care, and some evidence on dental care. That's something that often insurance plans in the US don't cover. So that's something that has a high out-of-pocket cost usually. So it seemed like people were using more care. However, except for the first year effects on mental health, we don't really find that this increased use of care translated into any better health on any of the measures that we see. So we have null effects, and they're quite precise. We can rule out very small improvements in different measures of physical and mental health. And we also don't find changes in other kind of health outcome measures like exercising, nutrition, those other types of health investments. So then as a point of comparison, we look at our treatment effects and compare them to this kind of cross-sectional association between income and health that we observe in our data, what I sort of motivated the talk with, and found that, we almost always can rule out that this is fully causal. And indeed, many times the treatment effect that we estimate is the opposite sign of what we would predict from these cross-sectional correlations. So at least in the sample we study, which again, I'll tell you more about it, but it's in the United States, so different setting than some of the other studies. And for the 3-year period that we do this intervention, it doesn't look like this cash transfer is really changing health in a permanent way.
Are we allowed to ask questions?
Yes.
Of course, please.
So I can't quite read the whole of it here, but I'm reading out. Can rule out the cross-sectional correlation between income and health and something. The causal effect is opposite sign.
I see. Maybe we could get this thing. In many cases, the causal effect is opposite sign. See if I can move this somewhere else or hide this.
But are you just making a general inference? That's very, very interesting, because I've always suspected this. But are you making an inference that if there is a correlation and it's not causal in the direction from income to health, it must be causal in the direction from health to income? Is that what you're saying?
Yeah, I think there are a few things. So it could be causal from health to income, or it could be that there's something that's affecting both health and income, like education, that is generating this correlation, but it's not fully causal. I think I would also, sorry, I'm trying to figure out how to hide this. Did you hide it?
Yeah.
Oh, okay, great.
We had too many windows, I think, so I just
Wonderful, thank you. Okay, sorry. Terrific, yeah. So there could be some third factor. There's actually quite a good amount of evidence showing that health does have a potentially strong causal effect on your income, looking at people who get health shocks and then their future labor market outcomes. But then the other kind of caveat I would put is this is there could be other reasons, there could be other causal relationships between income and health, where income drives health, but we're just not picking it up. For example, this is a temporary increase in income. A lot of these gradients that have been published are based on something that's more like permanent income rather than transient income. It could be that it's not just income today that matters. It could be that it's your exposure to having high income over a long period of time. And of course, when we look at the correlation, often people with high income today had high income yesterday, high income 5 years ago. So there could be other reasons, but just if we're thinking of it from a policymaker's perspective, and you're thinking, look at this, what would my prediction for the effect of this transfer be? Just based on these kind of naive correlations, you would have predicted that the transfer would have a big effect. And it's not, we don't see that in the data. So that's kind of the point of comparison that I think makes our results a little interesting.
Can I also?
Sure.
Another question. So we know as well that environment and neighborhood where people live in may have an effect on health. So even you are they give you this cash transfer, but you keep living in the same poor neighborhood, etc. That will have another. So yeah, the income is not the full picture, but
yeah, I think that's fully consistent with what we're saying here. Absolutely. So maybe it's not just you give people income and that improves their health. Maybe it's improving the neighborhood quality, right? Or encouraging them to move to better neighborhoods, or something that's not there could be non-income interventions that are not health interventions, but that nonetheless move health, right? And I think we have some evidence from that, from moving to opportunity, for example, the older study from the 90s where they sort of randomized housing vouchers, and some people were moved randomly to lower poverty neighborhoods, and they ended up having better health as a result. So yeah, this is not saying that other types of interventions couldn't affect health. Certainly they could. This intervention didn't seem to. Again, for our sample, for the period we study, et cetera, with all appropriate caveats.
Question as well. I wanted to know, is there any way in which you could make sure that the money transferred was employed in health aspects of their life?
No, so we specifically didn't do that. So what we wanted to see was, if we just give people cash and we let them choose themselves what they might spend it on, would that would that have improvements in health, right? So I mean, we're sort of thinking of this from the perspective of, again, a guaranteed income or a basic income, or even just a cash transfer program that you might have to alleviate poverty. Are there going to be health implications, mental health or physical health implications of that? So I think, you know, it's very, so in the paper, we kind of contrast this with other interventions you might do, like maybe give people health insurance, for example, right? Like that's much cheaper than this, has a much bigger effect on their health. So, you know, that's sort of our perspective. But we sort of very specifically didn't give them the money and say, spend this on your education or spend this on your income. We wanted to evaluate a totally unconditional gift.
Okay, thanks.
Yeah. Great. Okay. So, sorry, any more questions? I'm happy to take them. Okay.
No, I think we're good.
Awesome. Great. Okay, so just briefly, you know, I don't have a lot of time to talk with you guys, so I'm gonna give the literature review a little bit of a short shrift, but I would just mention some other recent RCTs that looked at unconditional cash transfers. These are all in the US. I know there's been some recent ones looking that you guys saw recently in Germany. But we've had a number in the US. They tend to be somewhat smaller in terms of the annual cash or the monthly cash gift. But for the most part, I would say they didn't find much evidence of health improvement. So I think we're pretty consistent with the literature there. One exception is this Chelsea Eats program. This was like a COVID relief program that was done in Chelsea, Massachusetts. Oh, my light's turned off. And it provided, I think it was $400 a month for 9 months. And they did find some improvements in food security and also some evidence of, you know, reduced use of emergency department care and things like that. So there's one exception there. But for the most part, I would say what we're finding is pretty consistent with what other studies have found as well. Okay, so a little bit more about our study. So the Open Research Unconditional Income Study ran from November 2020 through October 2023. So it was 36 months of transfers, $1,000 a month transfers. The study took place in 2 US states, Texas, which is in the south of the US. It has less of a welfare state. It's more of a conservative, libertarian state where they don't provide a lot of social benefits to their residents. And Illinois, which is more of a progressive state that does provide health insurance and other types of benefits to their residents. So we had sort of like one high benefit, one low benefit state in a mix of rural areas, urban areas, and suburban areas. We limited our eligibility requirements to having total self-reported household income not exceeding 300% of the federal poverty level. And participants were aged 21 to 40 when they were recruited. So they were about like 25 to 44 at the end of the study. We also excluded applicants who were receiving means-tested disability payments and those who were living in public housing, so the government-sponsored housing, or living with a household member who was receiving these disability payments. The reason for that is that our transfer would have made them ineligible for this program, and those programs are very difficult to get on. So we didn't want to make them ineligible for 3 years. Then we end the transfer period, and now they can't get housing and they can't get their disability payments again. So we excluded them for that reason.
Sarah, just a quick question.
Yeah.
Why did you limit it to 40? A little more
Yeah.
Because that's obviously a kind of a group that has probably like better. 20 to 40 is probably a better health period of life relative to maybe when medical expenses will be higher post 40. So
Yeah, I think that's a great question. I mean, I think on the health side, it's especially looking at health investments and mental health. It's a good group to look at. Young people, I know the data from the US actually have higher rates of reported mental health problems than older people. That's actually something that's like changed in the last 15 years. That's really interesting. And we might think they would be more flexible in changing their habits or their behavior, but they tend to be healthier, like you said. And the age group was not totally chosen for the health outcomes. We also wanted to see things like deciding to go back to college, changing careers, getting married, having a family, you know, sort of big life events that this cash might affect that are more common, having children that are more common during this age group. So it was also sort of selected for that reason
Because it
as
could well
well.
be that that age group would invest exactly in those sorts of events you just mentioned, while in an older age group, I could see that health expenditure is going to be a larger part of like their investment.
Yeah.
You know what I mean? So it might be, but just as a question.
Yeah, it's definitely possible, right? Like maybe if we had done this in an older age group, maybe we would have found different effects for sure. They might have more to invest in, right? Right. Okay, so just to give you kind of a high level of how the process works. So first we recruited people into the study. Most people were recruited with direct mailers that went to their address and had like a unique code to put into a website. The response rate to the mailers was pretty low. Only a few % of people responded to the mailers. But the people who responded on observable characteristics, at least, looked similar to the population we were targeting based on like census data telling us about the population. So that was reassuring. We recruited some participants through a mobile app that's used to manage your like cash transfer or food stamps benefits. If you're getting food assistance from the government, you have to be quite low income for that. We wanted to make sure to have good representation of low income people. So we had a banner that was on this phone app that people use to manage their benefits, recruiting people. And then we tried a little bit with Facebook and Instagram ads, but they didn't seem to work very well. So we didn't use them very much. In the recruiting process, and this was important for us, it turned out in the end, we told participants that they could get $50 a month or more. So they didn't know that what the or more was. They didn't know that there was this possibility of getting $1,000 a month. We didn't want people to be disappointed if they weren't selected or to experience harms of, you know, oh, I had planned to get this $1,000 and then I didn't get it, and now I'm really mad about that, right? So one good thing about that is the control group, for the duration of the study, didn't realize they were the control group. They were, for the most part, happy that they were getting $50 a month. So we had about 43,000 people do our online screener, which we used to determine eligibility, and about 14,500 of them were eligible based on the criteria I just described. So then we did the first of 2 randomizations. We either selected them to potentially be part of the study or to not be in the study at all, and we didn't contact them again. This randomization depended on observable characteristics, so we oversampled certain groups. We oversampled the poorest people. We oversampled racial and ethnic minorities. We oversampled men because we were trying to get a sample that looked like the way that we wanted, that had good representation of different groups, that oversampled low-income people, and that was roughly representative of the gender mix. So then once we had our list of people in the sample, we enrolled them in person for the first half. Unfortunately, after the first half of enrollment, COVID hit. We had to pull all the interviewers back from the field and retrain them and do over the phone enrollment. But we did eventually get everyone enrolled, 3,000 people enrolled. And then once everyone was enrolled, we did our second randomization, which is the focal randomization for this talk, which is either, so as soon as they were enrolled, they started getting $50 a month. And then we did the randomization, and then either they were called and told your amount you're getting is going up to $1,000 a month, or they just continued to get the $50 a month that they had been getting. This second randomization was unconditional, so everyone in the sample had an equal probability of being in the treatment group or being in the control group. Okay, so I'm going to just, this is just some details about the randomization, which I'm happy to chat about, but just in the interest of time, I think I'll skip, but feel free to stop me if you want to talk about them more. A little bit about our characteristics. So as it was already pointed out, the age is pretty young. Average age is about 30. It's about 67% female. We have about 30% non-Hispanic Black, 47% non-Hispanic white, and about 20% Hispanic. About, a little bit under 60% of people have a child in the household. About a little under 60% of people are employed, and their household income is just a little bit under $30,000 a year. So, it's a relatively low income group. Average household size is of 2.9 and household income of less than $30,000, but it's not like also, extremely, extremely poor. In terms of their access to healthcare at baseline, so about 30% of them didn't have health insurance, And as I mentioned, about a quarter reported skipping medical care due to costs. They also had relative to the population their age, high usage of hospital and emergency department care, and reported somewhat poor mental health outcomes. Only about half of them said they had very good or excellent health also, which again for this age group is quite quite bad. I mean, for this age group, we might expect that to be more like 75% of them saying their health is very good or excellent. But I think part of this is because this is a low income group, so they're more disadvantaged, and they are expressing worse health. Okay, so the payments started in
Sarah, I'm surprised that so many people are insured at 70%. I thought that's something that, is very uncommon and maybe too expensive.
Yeah, so there's 2 states in the study. Half the sample is in Illinois. Illinois provides free health insurance to low-income adults. And then the other half of the sample is in Texas, which does not. So the participants in our sample, almost 60% of them work, and most of the people who work get some kind of employer-sponsored insurance. And then some people purchase insurance through the health insurance exchanges, which are also subsidized. So they're expensive, but they're the government helps pay for part of the premium. So that's mostly where people are getting, mostly through employer-sponsored insurance or Medicaid, which is the free program. The remaining 30% uninsured are mostly in Texas. So a larger fraction of the Texas sample is uninsured because Texas doesn't have this program of insurance for low-income people.
Will you be looking at them separately as well?
We do. So we're doing a revision now, and we've added that cut. I don't think I've updated the figure in the slides. I'm trying to remember if I did or not. But it actually doesn't look that different. One thing we do look at is just, were you insured at baseline? Is it different for the people who were uninsured at baseline?
Yeah.
And that also doesn't look very different. The biggest thing I'll say is like a little sneak peek, I guess. The biggest thing that seems to matter for the heterogeneity analysis is this variable. If you said at baseline that you were skipping medical care you needed because it was too expensive, for that group, we see it's basically the only group where we see like benefits that are kind of across all domains. So they report having better access to care, they report using a lot more care, and they're the only group, it's not statistically significant, but their reported health improves, but it's not significant, and their mental health improves. So that seems to be, I think, an interesting finding, and I think it sort of speaks to the fact that, for a lot of people in the sample, health is maybe not their priority, right? They're spending the money on transportation, they're spending the money on leisure or other things, but there is probably some subset of the sample where health is really the thing they want to spend it on. So we're doing some follow-up work now to try to get at that a little bit better. So that was kind of an aside. But great. Okay, so just a little more on the program. I already told you the dates. It was administered through some local nonprofits. The payments were not taxable, and most other government benefits were protected. So if you got this health insurance, Medicaid insurance through Illinois because you were low income, now you get this transfer. It didn't make you ineligible. The government didn't count the transfer as part of the eligibility criteria for these programs. So you can really think of this transfer as being on top of whatever the government is already providing in terms of these assistance programs, for the most part. Okay, so data, we collected data from a few sources. So every month we sent them an online survey that they could do on their phone or they could do on a computer. And one reason we kind of did this so frequently was because, first of all, it helped us keep track of the participants because it's a very mobile sample. Many of them moved or they had their phone shut off. They got a new phone number. They got a new address. So contact with them regularly really helped us keep up-to-date contact information. Also, it gave us multiple chances to get the information we were looking for. If we asked a survey question in February and the participant didn't respond, maybe we asked it again in June and they did respond. So we're going to treat information that's collected in the same study year as sort of capturing the same information. So if we just saw you in June, we would use that as your year 1 response. So in addition to these phone surveys, that they would just do themselves, We had 2 enumerated surveys where an interview would like, call them up and ask them questions, record their questions, or meet with them in person, depending on how hard they were to get a hold of. So we had 2 sort of bigger enumerated surveys. We also had a mobile phone app that we used to collect kind of more complicated data. So how are you using your time? We had like a time diary where they could drag and drop, kind of looks like a Google Calendar thing. And we asked for 1 weekday day and 1 weekend day per month to be recorded through that. We did blood draws. I'll tell you a little bit more about that to measure different underlying clinical measures of health, like their blood sugar or their cholesterol. We also had at the blood draws, since it was a trained medical professional doing it, they also took their blood pressure and their height and weight so we can get BMI. And then we have some administrative records we don't use so much in this paper, but we do look at medical debt, which is on their credit report, and mortality rates, which is from Social Security records that are held by the Census Bureau. Okay, so we're very happy with our response rates to these. It turns out if you give people money every month, they respond to your surveys. So we have very high response rates in both treatment and control. I think this was partly because control was masked and they didn't realize they missed out on this money, so they were still willing to respond to our surveys. We have a follow-up study that we're doing where it's in partner with a local government, and there isn't this masking. The control group knows they weren't picked, and I will just tell you, they are not responding to the surveys very well. So that was a good thing for this study. We do see that the treatment group does respond at somewhat higher rates. So this like light grayish blue bar is higher than this sort of brownish bar. And these differences are statistically significant for end line, for year 3. So we do some robustness checks in the paper to think about this differential response, but overall pretty good for the surveys. For the things that are more complicated, more burdensome, we have lower response rates, as you might imagine, and we have more difference between treatment and control. So nutrition diaries ask them, in the last 24 hours, what was everything you ate and what were the portion sizes? And it takes a long time to fill out. It's very boring to fill out, to be honest. So response rates are lower there, and they kind of fall over the period of the study. Same with the time diaries. It asks, what have you been doing the last 24 hours? Put in every activity. Takes a while to fill out. And then the blood draws, obviously you're having a phlebotomist go and collect blood, and people don't like needles, so the response rates are lower there too, especially in the control group, although they're higher than I thought they would be, honestly. If I was in this study, I would not have given my blood. So I was pretty pleased that we had over half of the people being willing to participate.
The interesting thing is that the $950 more don't buy you so much percentage points in response rate. 50 is enough actually to get like quite a lot.
Yeah.
It's astonishing.
Yeah. Yeah, I think that is really surprising. So definitely. I mean, sometimes I'm asked when I show this figure, how did we get such high response rates in the control group? And I think the fact that we pay them $50 every month, even though it's like a lot less, they have a reason to, it was totally unconditional. Like if they didn't respond, it's not like we turned the money off. And we made that clear. That was actually part of the tax treatment. It had to be like that. But they stay in touch, right? And they know when the money is going out. Like if there's a delay, they contact us. They're very aware of the study. So, but yeah, great. Okay, so randomized controlled trial. So the estimation is pretty straightforward, especially since we don't have different treatment probabilities. We don't even really need to include straight fixed effects. We do include these baseline covariates to improve precision. We collected like hundreds of baseline covariates, a very long baseline interview. And so instead of just including all of them, we first do a model selection procedure where we select which to include with the lasso, and then we include the ones that are selected for each variable. So we have results for like every year. We'll have like year 1 results, year 2 results, year 3 results. But to avoid having just a massive number of numbers in our table, we're going to show you, and I'm going to show you a weighted average of the 3 study years. And the weights we pre-specified, we said we would put more weight on the observations towards the end of the study because we had thought it might take some time for the cash to have an effect. So we decided to put the most weight on the last year of the study and less weight at the beginning. course, at the time, we didn't know that the biggest effects we would find would be at the beginning of the study. So what are you going to do? That's why you pre-specify, I suppose. But that's how we're going to do our pooling over time. So I'll show you just the results, but then also we have a lot of different categories, a lot of different outcomes. And to sort of organize these, we've grouped outcomes together so that and created kind of index values. So for example, you might think about something like, did you go to an office visit? Did you have a cholesterol check? Did you have other cancer screening? These are all different measures of getting office-based care or getting primary or preventive care, right? So we take all the things that measure primary care, we aggregate them up, we scale everything by the standard deviation, aggregate them up into sort of a primary care index. And then within, kind of a broader group, we can think about primary care, we can think about other care that you might get, and aggregate that up to like all office-based care, all care you might get in an office, right? So there's going to be sort of family level estimates of the effect, and then kind of these sub-indices, and then of course just the underlying variable themselves. Did you have a cholesterol check, et cetera. And last, another challenge because of the large number of observations is, of course, we might have some false positives. So we're going to also provide p-values that are kind of adjusted to control the false discovery rate. And we hold our main results, which are going to be all the results I show you, to kind of a lower standard than our exploratory results. So we just adjust within our main results. And then for like our heterogeneity analysis or our year-by-year effects, we adjust across all of the tests. Great. Okay. So let me start by showing you, so I described, hopefully well enough to sort of understand this aggregation that we used, where we have all these sort of sub-questions, and then we put them all in standard deviation terms, and then we take the average to make kind of a high-level index of the effect. And so this is showing you those like high-level, family-level, we are calling them index effects. They're measured in standard deviations. So they're taking all of the different questions that are in these different categories and aggregating them to a single thing. And so what do we find? So first, these 4 families are measuring health outcomes, self-reported mental health, physical health, biomarkers, it's from the blood draws, and then mortality. The height of the bars is the treatment effect that we find. And then I've also plotted here these little gray dots with 95% confidence intervals. These are the predicted effect of the transfer just from that cross-sectional correlation. So I was saying, if you just looked in the control group and you looked at the difference on average between people who made, $12,000 a year more versus $12,000 a year less, and you just took their difference in their outcomes in the control group, what might you have guessed this effect would be just from those differences? So I provide that as a point of comparison. So you can see, like, for example, for mental health, we don't find a statistically significant effect. Maybe, the bar is going in the wrong direction, so maybe a somewhat worse effect, but not statistically significant. We would have predicted, we would have found a big significant improvement, right? So this is just a point to compare. Same for physical health. We don't find an effect. It's not significant. We can rule out small effects. We would have predicted an improvement in self-reported physical health. For biomarkers, for mortality, this is all the same. We don't find any significant effects here. Then we look at, well, okay, maybe if health isn't changing, maybe some inputs into health are changing. And so we might expect later on that there could be health benefits if they're making the investments now. And here we see some surprising things, but I think something that's maybe pointing a little bit more towards this. So surprisingly, we don't find much of a change in people's reporting that they're able to access medical care better. This was very shocking to me because the questions are things like, can you afford all the care that you need, right? I would have thought giving more money would make it easier to afford. But we do see that they are getting more medical care. So we see an increase in office-based care. So it's a positive, small but positive effect, and then an increase in hospital and emergency department care. So this is one example where we would have predicted hospital care would go down. Actually, higher income people use less emergency department care, but we actually find that it goes up.
Sarah, could I ask a bit about how you're interpreting? Because as you just suggested, I mean, in the UK context, for example, you would use emergency care as quite a good way of, from data on healthcare usage, of getting at health outcomes, because emergency care is free. Therefore, when people have bad health outcomes, they go to the emergency department. I get the impression you might be, in this context, you might be suggesting something different, which is that people who have a health emergencies, but there's sort of out-of-pocket costs or something, and therefore they don't use emergency care, but when they have this cash transfer, they do use emergency care. But it's quite surprising that using emergency care when you have a health emergency doesn't translate into any health outcome improvement, because that's quite sort of. So I was
Yeah.
just wondering how you're interpreting, because there's two ways of looking at like emergency department care as
Yeah.
a measure of a health
Well,
outcome, because it's an emergency
absolutely.
and it's a measure of use too.
Yeah, so I'm interpreting it as sort of the latter interpretation. Going to the emergency department can be quite costly in the US, especially if you don't have insurance or if you have not very good insurance. And same with the hospital. And so I think this is probably reflecting the fact that you can afford to go more if you're having some health problems. And I agree, it's surprising. They're using more medical care. I mean, we might also think that this office-based care, right, is also going up. Maybe this would also improve health. We're not really seeing it show up in health yet. So, I mean, I think one thing I try to be careful about when I talk about it is it's possible that they're getting this care now, and maybe in 5 years or 10 years, we start seeing that come to fruition. But it's just not over this time period, at least, I would say.
Do you have any disaggregation of what types of care beyond emergency versus office-based, like what types of care they are seeking more of, in the sense of, like code lists, health code lists or something like that?
Yeah, I'll show you a little bit more. We
Okay,
unfortunately
perfect.
don't have administrative records. We've been working very hard to get them, but we haven't successfully gotten the administrative records for the hospital. So we don't have it super broken down, but for office-based care, we certainly ask about different types of care you might get in an outpatient setting.
So these measures are not based on administrative data, they're self-reported.
So this is administrative, and this is blood draw.
Yeah.
The rest are survey.
Okay, sorry, I thought they were.
Yeah.
Okay.
Yeah, definitely. And then we look at other types of health investments, non-medical care investments, but investments you might make through your behavior, like having higher quality nutrition, or exercising, sleeping better, or using drugs and alcohol. These don't seem to change very much, I guess is my takeaway. Right? So basically, it looks like medical care use is going up. We don't see any changes in health over this period again, and we don't see any changes in like health behavioral kind of elements. Okay, so this is at the high level, and so now I'll show you some on a little bit more like the nitty-gritty of what's underlying these things. So first, for self-reported health, this effect is what was plotted in the previous figure. So this is just aggregating, this table actually has two parts, there's more on the next slide, but aggregating these sort of like sub measures of self-reported health, physical health up. We don't find an effect overall. We don't find any improvements in different survey measures, like the number of days your physical health was good out of the last 30. Actually, if anything, maybe it goes down a little. If this were significant after adjusting for multiple comparisons, there would also be another symbol here that looks like a little dagger. There's no symbol there, so that means it's significant with traditional inference, but not after adjusting for multiple comparisons. Then we ask a bunch of questions from a well-known, widely used survey battery called the SF12 about does your health limit you in doing moderate activities? Does your health limit you in doing different things, right? So of course, we don't find significant effects, but when you don't find a significant effect, you might wonder, well, is this just very noisy? Are we really learning something? So in this column, I'm going to show you the size of the effect that we can rule out. Is this just imprecise? And it doesn't look like it's just imprecise. We can rule out, overall about 0.02 standard deviations improvements in these measures, which is quite small. And then, for many measures, you'll less than a 4%, for all the measures, less than a 4% improvement in the outcomes. Just to be clear, for some things like this, we have like these different submeasures of it. And when we have these submeasures, we again aggregate up. We really went crazy with the aggregation. We aggregate up to sort of a sub-index, right? So that's why this is measured in standard deviations. This is a 0.05 standard deviations. When we do the aggregation, we always orient so that higher is better. And then lastly, in this column, I'm going to show the predicted effect. What would we have just predicted this transfer would do based on the control group's cross-sectional variation in income? And for most of these measures, we would predict, for all of them, we would predict that they would improve. The health limitation ones, higher means more limitations. So that's why that's negative. All right, and so, okay, so that's kind of how the tables are set up. I know I'm not going to sort of go through every little thing because I think, first of all, I don't have a ton of time. I want to make sure there's time for discussion and questions. But also, I think the family level basically tells the story. We don't see any improvements in self-reported physical health in any of these composite measures, and our estimates are quite precise. We don't see many changes in physical health measures of stress or mental distress. Again, we can rule out quite small improvements. These are additional measures about depression, anxiety, other measures of mental health. We don't see improvements. For the most part, the time patterns are not super interesting, which is why I haven't shown you like the year-by-year effects. But I think for mental health, it's kind of one exception where we do see kind of a big improvement in year one. This is the stress score in standard deviations, almost 1/10 of a standard deviation reduction in stress. But then by year two, you can see that it's basically 0. And then in year 3, and this is possibly because the transfer is ending, the treatment group's actually reporting a little bit more stress than the control group. For biomarkers, again, I'm just going to go through this kind of quickly in the interest of time, but these are from the blood draws. It's a little bit noisier, but when we aggregate up to, the family level, we can reject like quite a small improvement. Each measure is a little bit different in terms of the precision. These are more biomarkers, so cholesterol, markers of inflammation don't seem to change. Obesity rates don't really seem to change. So we don't see a lot in terms of these clinical measures of health. On mortality rate, we don't see much going on, although the mortality rate in this young sample is quite small or quite low. So it's not we can only reject like sort of very large improvements. So this is kind of TBD, I think. Maybe as the sample ages, we'll see something else. So office-based care. So I got asked about. So we have different ways of measuring this. So just first, total out-of-pocket medical spending, excluding insurance premiums, goes up by about $20 a month. When we look at primary care, it doesn't look like much is going on. Maybe a slight increase in the number of primary care office visits. We do see, switch over, maybe a small increase in specialty visits, and then dental care. Again, in the U.S. context, this tends to have a lot of out-of-pocket costs associated with it, and it's not included in a lot of insurance. So we do see dental care seems to be going up, especially the probability of having any visit with the dentist. When we look at sort of preventive care, we don't see much changes. If anything, maybe slight negative on the COVID vaccine, which is a little concerning. I think this has to do with, we also see some reductions in people's labor supply. And during this era, a lot of people had to get the COVID vaccine, like their employer required it. So if fewer people are working, there might be less of an incentive there. Hospital and emergency department care, we are working on getting administrative records here, but we don't have them. This is survey data, but we do see that both emergency department care and hospital-related care seems to go up, about a 10% increase in emergency department care and a bit less for hospital care. But those do seem to go up, so we might think that would yield benefits in the future. Measures of access to medical care, things like having insurance coverage, well, it's a positive effect, but not statistically significant. And then measures of being worried about paying for your bills, et cetera, don't seem to improve. One thing that's kind of interesting is, you see a little bit of a worsening of saying that they skip dental care due to costs. I think to some extent this makes sense. A lot of people, again, in the US, just don't go to the dentist if they can't afford it. Then they go to the dentist and they find out, oh, you need $30,000 of dental care, right? And so It's one of these things where you might actually be feeling like you need to skip. Now that you know about the care that you need because you actually went to the dentist, you know that you're skipping things that you need. So I was surprised this access didn't go up. We look at things like, prescription drug access, etc. So health investments, exercise and sleep. Sorry, I'm a bit repetitive here, but we don't see any evidence that people are sleeping more or that they are exercising more as a result of the transfer. We can rule out very small improvements. If anything, maybe it's going the other way. When we look at nutrition, maybe a little bit of evidence of maybe slightly better nutrition in the diet and behavior category. The healthy eating index is derived from the food diaries, and it's trying to measure how well your food consumption is lining up with dietary recommendations from the government. Also, maybe a little bit less likely to say they're drinking regular sugar. Food insecurity is very interesting because it follows a similar pattern as mental health. Sorry, this is, I should say food security. This is oriented so that it's positive. We see big improvements in people reporting they're more food secure. They're better able to afford the food they need in the first year, but then it kind of falls off, right? And so the year 1, 2, and 3 are the Qualtrics online surveys. Midline and endline are the enumerated surveys. And so by endline, we don't see any better food security in the treatment group. We have this same kind of dynamic pattern that we saw for mental health. Unhealthy behaviors, we don't find very much of an effect, maybe drinking a little bit more alcohol, but it doesn't remain significant after adjusting. Also sort of decrease reports of saying that drinking was interfering with their responsibilities. So it's kind of a wash on the unhealthy behaviors. Smoking doesn't seem to change very much. Drug use doesn't seem to change very much as a result of the transfer. So the last thing, sort of result I'll show, which, and then we can have some discussion, is about, treatment effect heterogeneity. You might expect there to be really different effects within the sample for people who maybe had insurance or didn't, or had better or worse health. We just don't find a ton of treatment effect heterogeneity. It's not super interesting. So this is for self-reported physical health, the family level measure that's reported in standard deviation units. You only see one group where it actually looks positive. And again, that's the skipped medical care group, the group that reported skipping medical care at baseline. I didn't include these in the talk because of time, but you can see them in the paper. They also have bigger increases in office-based care and bigger increases in hospital and emergency department.
Oh, we stopped hearing you. Can you still hear us?
Yeah,
Oh,
can you hear me?
back.
Sorry about that. Okay, that's unfortunate. Again, for mental health, this is kind of the only group that it looks like there was an improvement. Oh no. Okay, I'm not sure. Can you still hear me?
Yeah.
Okay, good. Okay, I was worried I cut out again. All right, perfect. It's almost the end of the talk anyway, so it's a good time for the technology to go off the rails. So I'll just end with a little bit of a discussion. So, in this health policy space, there's been a lot of enthusiasm for the idea that we should be intervening more on the non-medical side. Non-medical interventions like poverty alleviation measures might be the key to reducing health disparities. But at least over the sort of the time horizon and the setting that we have here, we don't, it doesn't seem like this is the most cost-effective way to do that. What we like as economists about cash is that people can spend it on whatever gives them the highest, marginal utility of consumption. And some people are going to spend it on their health, but other people are going to spend it on their transportation, or they're going to spend it on housing, or they're going to spend it on other things that don't directly improve their health. And that's good. That's one thing that makes cash efficient. But what it means from a researcher's perspective is that you're sort of taking an average effect over maybe a lot of people who are not spending anything on their health and a small group that are spending a lot on their health or prioritizing that. And so on average, you might not find much is changing. Or put differently, Cash, unconditional cash, might just be a rather blunt instrument for moving something as specific as health, right? So my sort of takeaway from these results is that if you're really interested in health as a policymaker, if that's what you're laser focused on, you are probably going to get more bang for your buck if you target programs that are directly targeting health, like subsidizing medical care or providing easier access or transportation to medical care specifically. There's been great RCTs that look at things like expanding health insurance in the US or helping people get to their primary care appointment, et cetera. They find they're much, much cheaper than this intervention, and they find much bigger effects on use of medical care. But if you just care about inequality, consumption, giving people the freedom to spend their money on what they want, nothing in this talk needs to make you change your mind on that. It's just if you care about health specifically, this doesn't seem like the tool to move that. Again, over the time period we study, for the sample we study, it could be different in other settings. One thing we sometimes discuss is, well, if we had done this for 10 years instead of for 3 years, would we see big improvements emerge, right? Was this just too short? I think there's reason to be optimistic and pessimistic about the idea that a longer transfer would generate bigger improvements. One reason to be pessimistic is a lot of the proposed mechanism between poverty and health is through stress and through having a lot of stress and dealing with it. And so the fact that we don't see kind of more prolonged improvements in stress, even by year 2, they still have a year and a half of the transfer left, I think is a reason to be kind of pessimistic. Also, we think that behavior is probably generating a lot of the health outcomes that we see, or some of them at least, but we don't see behavioral changes. But at the same time, I think you could also be optimistic. We do see that they're using medical care, hospital care, emergency department care. If you're having medical emergencies, this should be very efficacious, right? And so getting more healthcare can have long-run benefits, although I would also argue that there's cheaper ways to get people to use more medical care than giving them an unconditional $1,000 a month transfer. Okay, and then the last thing I'll say is, I want to talk to you about health because of the topic of the seminar, but of course, many other things change when you give people money. Certainly, we measure their consumption very closely. We see really big increases in things like food, housing, transportation, spending on their children. They're more likely to move. They tend to move to new labor markets, new housing units, new neighborhoods. So we have big changes in moving. They worked less. We saw about a 1 to 2 percentage point reduction in labor supply at the extensive margin. They also worked fewer hours per week, longer unemployment spells. They changed how they were using their time. And we see some improvements in self-reported measures of parenting for those who had kids. Things like monitoring their kids more closely, supervising their kids more closely, using less corporal punishment, and spending more on their kids. So even if the parent's health doesn't improve, perhaps down the road, the kid's health could be better off. And we're interested in looking at some more things that we haven't had time to delve into, but like involvement with the criminal justice system, childbearing, longer term effects, etc. Okay, so I think I'm out of time, so I will stop there, but I'm happy to take any questions that are lingering. No? Okay.
Thank you, Sarah. It was a really
Yeah.
good talk. I was wondering if you could speak a little more about labor supply, because I have a feeling this could be coming from the perspective of a literature on state pension age, which is in the UK, essentially universal basic income above an age threshold. And that that literature is using reforms to the age finds very mixed effects on health. But one of the things that comes through is that some measures of physical health go down. And the explanation there is that people become inactive. Being active is good for a range of physical health things. So I'm wondering, A, a little more about the magnitude of those effects on labour supply and participation at work, and B, if you've thought about any how this might be acting as a mediator in any way. Because
I think
do things in opposite directions to some of the other effects of income, like paying for more healthcare.
Yeah, definitely. I think it's a great question, and of course we struggled a little. We wanted to look at a lot of things, but it's hard to put everything together. But certainly your labor supply could affect your health, as you said. If you're more active, if you're more engaged, maybe you have more sense of purpose. you know, on the flip side, if you're in a very stressful job or you're in a job that's physically demanding or whatever, it could make it worse. So we looked at a lot of things in the labor dimension, the employment dimension. You know, labor supply is what we talk about the most. We see like the probability of working at all went down by, I think, like 1.6 percentage points. I'm remembering off the top of my head, but you can see the paper. Average hours worked per week went down by a few hours per week. But then there was also changes in like jobs, people's labor market earnings went down. So if I recall correctly, I think about a third of the transfer went to was eaten up by reduced household earnings. There was also some evidence of the partner, if you were living with a partner, also reducing their labor supply a little bit when this unconditional cash transfer went in. But then I think,
what were the percentage points sort of reduction? Sorry, I might not have caught them.
sorry, it's so on the extensive margin, it was about a 1.6 or 1.7 percentage point reduction.
Okay.
Yeah, and we have like labor supply elasticities in the paper and
Yes.
like marginal propensity to consume stuff. I think actually to me, what's more interesting in the labor paper, I'm not really a labor person, so maybe this isn't a good perspective, but a lot of the non-labor supply outcomes to me are more interesting, like job amenities, how much do you enjoy your work, how much are you searching for work, does your manager treat you fairly, stuff like that. So we looked at a lot of stuff like that. That didn't seem to change. That was one dimension I had thought maybe they'll work less or they'll switch jobs, but they'll go to jobs that they enjoy more for whatever reason. So, but yeah, we collected a ton of measures of that kind of stuff. Oh, now my face is really big though. But people didn't find them as interesting. I think they, in the review process, they got moved like to the appendix or so.
Banished.
Anyway, yeah, banished to the appendix, exactly.
Thanks, very interesting. So I work at the Department of Health here in the UK. And in the UK, we have national healthcare system that is free at the point of use. That means it's paid back through taxations, and people don't have to pay when they go to visit most of the things. There are not many co-payments, but we still observe a lot of health inequalities. I mean, what you say about, I understand in the US, and it's what I think how we can transfer this kind of studies across such a different setups, because even here you suggested just make something more targeted for people to have access to free or access to healthcare services. But in countries that we have it, we still observe massive differences. So the life expectancy in the UK of a person that lives in the wealthiest area compared to the person that lives in the poorest area is 10 years. So I struggle to understand, I mean, and that's obviously linked to deprivation is multidimensional, it's income, but there's education, so there is an index that is complex. So, but I keep saying to my colleagues, you know, we do a lot of things to reduce health inequalities, but we don't reduce socioeconomic inequalities, that I think is one of the drivers. We are not gonna get this solved. So how my message seems to not really into yours, or I don't know if I mean, there's so many nuances to take into account, but just say that in countries where people have access, in theory, many people of any backgrounds, anything, so have problems to access. So yeah, it's complex, but yeah. Well, economic inequality is a massive driver of that. And I think the healthcare system needs to go beyond, and
that's very interesting. Thanks for sharing that. I mean, I think the effects of something like this could potentially be very different in the UK, where you don't have, you know, the need to spend. People who spent this on their health took the money and they spent it so that they could go to the emergency department or they could go get dental care, right? Like, and so if you don't need to spend your money on that, maybe you're spending it in a different way because it's coming out of your paycheck in the form of taxes. But, you know, I could certainly believe that there could be a different effect in the UK. The other thing, though, I would say, which we discussed a little bit, is the the causal arrow can go both directions, right? So like some of the health inequalities are reflecting the fact that if you're in poor health, you're going to have less success in the labor market, right? And so I think there's good evidence that that's true if you experience a health shock, and that's why we have disability insurance and disability benefits programs and things like that, right? So I think it's a little tricky in that sense. And then, yeah, I mean, I know I talked about like targeted health interventions, and it's a little bit US specific because, of course, we don't have a national health care, but there have been other like interventions that have shown to improve health. Like there was a really nice RCT that showed helping people make a primary care appointment and getting transportation to go to it helps, reduced unnecessary emergency department visits, for example. So that's something that's not making care cheaper, but just making care specifically easier to access. So, I mean, I think things like that could also be promising.
Yeah, and here it also happens, like people live in London, transport can be quite expensive. So people very low income wouldn't go to the doctor because they have to pay £10 to go to the tube to go to hospital. That's quite sad.
So one more question.
Yeah, this is related to one of your earlier points about like self-reported outcomes in the job market. So you mentioned that things like job satisfaction and like those more subjective measures in the labor market also show no significant differences. I'm wondering was that different through time as well, whereas like in the first year, self-reported job satisfaction or like well-being at work was higher, and then it diminished over time? Because I noticed with like the mental health pattern, right, that was the sort of pattern you observed, and I'm wondering if part of that could be driven by the fact that people in general for mental indicators tend not to have a very good measure of like absolute measures of happiness, and so kind of no matter what, over time we tend to see people regress to the mean or just like an average level of happiness or well-being.
Yeah, that's a good question. I will admit that I don't recall off the top of my head what the time patterns were. I don't remember them being, for the employment stuff, I don't remember them being super interesting though. I feel like I would have remembered if they had the same pattern. I'll say like we did this pattern of like improvements in the first year that fade away. We did see for things like other psychosocial measures like life satisfaction or affect balance, how happy are you feeling? We saw the same kind of pattern where big improvements year one, and then there was like an adjustment. With employment, like, so I don't remember the like subjective measures of employment, like how much do you like your boss and stuff like that. But the labor supply effects were like basically immediate, and they were flat, and then the transfer ended, and then people went back to work. So there wasn't like this thing where it was like a big reduction in labor supply at the beginning, and then they got back into it, or vice versa. It was very much like a level shift, and then of course now we can see the post-transfer eras, and then it just popped right back up. So, but if you look at my website, you can find a link to the results for employment. Check those out. Yeah.
And one final question.
I was wondering whether besides affordability, also access plays a role when it comes to food and healthy diet, for example, because for my experience from the US, it's not only the affordability when it comes to money, but also that sometimes the next grocery store with healthy food is like 20-25 minutes away. So do you see any heterogeneity, or do you have any chance to look into that, divided by whether there would be the chance to improve that, or whether it is not possible at all?
Yeah, that's a great suggestion. We haven't looked at that. So that could be an area of heterogeneity that would be interesting. I mean, we tried to get at this diet quality through this healthy eating index, and that did show a little bit of an improvement. So it's possible that in some areas, people were better able to access this care. Maybe that would be a big access this food. It would be a bigger improvement. Yeah, I'm not sure. I mean, I would say more than half the sample lives in an urban area where there might not be a grocery store nearby, but there is public transportation and things. If they, it's not like they're in a super rural area where they'd have to drive 45 minutes to get to the grocery store. But some of the sample is, I mean, we did deliberately recruit people in rural areas too. So, I mean, that could be an issue for sure.
Okay, Sarah, I think we already took enough of your time
Yeah.
because we're 11 minutes after the hour. So thank you so much for coming, and
My pleasure.
really lovely, interesting results. And we hope to be in touch.
Yeah,
Keep in
thanks so
touch.
much. Thanks for having me.
Okay,
Thank you.
thank you. Bye.
Bye.